Good morning. Thank you for being here. It is my distinct honor, along with my co-chairs, Dr. Sunny Goel and Dr. Andrew Holzman, who is in the room somewhere. I saw him earlier. Will be here shortly, as long as he's not mic'd. To welcome all of you to the inaugural Capital Refractive Surgery Forum. So let's give a hand to everybody here. We have curated a passionate group of physicians and providers and eye care specialists to discuss everything from ocular surface disease to the refractive panel of surgical processing, from keratorefractive surgery, from lens-based surgery, to anything that's going to provide a patient a refractive advancement. We also have pharmacologic technologies that are out here that we're going to discuss. I mean, we have a wonderful group of providers here that are going to go over all of this. It is a process that is evolving, so your feedback is really important to us. We want to make sure that we provide to you what it is that is most important. There have been changes in the marketing of refractive surgery. There have been changes in the way we communicate with our patients regarding refractive surgery. One thing that has also changed is the technology is really unparalleled at this point. So how is it that we are able to share our understanding of this technology to the community at large? And that's going to come primarily from those of you in this room. Myself, Dr. Holzman, Dr. Goel, we are looking at over 300,000 cases of refractive surgery. And as all of you know, the vast majority of these patients do unbelievably well. The understanding, however, doesn't always reflect that, and it really is important that we as a group, we as individuals who are looking at these patients every day, express the most up-to-date understanding, the best way for us to kind of provide the type of care that we're looking to do every day to our patients. We have family members that are in the area. My brother has come here all the way from the West Coast to kind of share his experience at a section that we're going to go over. These are my eyes, why I chose what I did. We have individuals from the pharmacologic world who is going to talk to us about some of the newest products for presbyopia management. And in large part, we want to make sure that this is a family-type environment, as if you are in, as we like to joke, you are in our living room. So it's an opportunity for us to have a dialogue. It's an opportunity for us to have a back and forth. It is not a stage. As you can see, this is not set up like a traditional lectern and audience scenario. We really want engagement, and that's really what we're going to go for here. And so don't hesitate if you feel like it's motivating you to just yell something out and say, I have a question about this, or I want to talk about that. We may not get to it at that moment, but I assure you, we will address every single one of these questions that you have as part of this first inaugural Capital Refractive Surgery Forum. And so you'll see a lot of the presenters in the audience sitting next to you. You'll also see, as I said, my co-chairs in and around. Don't hesitate to reach out, to just grab any one of us to kind of go over whatever it is that's on your mind as it relates to this. And once again, thank you so much for being here. Thank you so much for giving us a Sunday. We have a beautiful venue, a great group of people. I'm going to go ahead and introduce our first moderator, Dr. Nancy Draskovic, and we're going to start this off by going over what we know to be the basic foundation of refractive surgery, and that's understanding the ocular surface. So without further ado, Nancy Draskovic.
Hello, everyone. Thanks for having me here, and thank you, Dr. Solomon, for your introduction. Here's a list of my disclosures. And moving forward, why do we care about dry eyes? This impacts most of our patients every single day. It's very common, yet very much underdiagnosed. It's chronic, it's progressive, it's multifactorial, and it impacts our daily function. Currently, we have a whole toolbox full of medications and other devices that can be used for the treatment of dry eyes. We have artificial tears that really just give us some symptomatic relief but don't do anything to actually treat dry eyes. We have a bunch of anti-inflammatory options, things like cyclosporins in various concentrations, lifitegrast and corticosteroids. We have regenerative products like Oxervate and other agents that are tear film stabilizers such as perfluorobutylpentane and perfluorohexyloctane. Punctal occlusion options, whether it's collagen or silicone plugs. We've got newer hyaluronic gel plugs that you'll be hearing about a little bit more later. And then bottom line is we really always have an unmet need. We're always looking for something that's going to work faster, something that's going to be much more effective, and something that's going to be well tolerated by our patients. Here we have a brand new medication called Acoltramon. This is first in its class TRPM8 receptor agonist. It was just newly FDA approved as of March 28th of this year, and it was approved for the treatment of signs and symptoms of dry eye disease. Indication of use is really for those moderate to severe dry eye patients. It has a very rapid onset. It has been shown to be very effective. It's tolerated very well by patients, and it does come in a single dose vial with BID dosing. So TRPM8 receptors are really the key regulators of basal tear production, and Acoltramon does trigger these TRPM8 receptors to secrete those basal tears. The TRPM8 receptors will detect small changes in temperature and osmolarity, and that will then in turn activate the trigeminal nerve to secrete a basal tear. And it is stimulating all of the lacrimal glands, the meibomian glands, as well as goblet cells to produce that good, hearty basal tear. Well, how does this work? So the efficacy of Acoltramon was studied in 931 patients in 2 simultaneous phase 3 studies. It's Comet 2 and Comet 3. They were checking to see what the unanesthetized Schirmer scores were going to be in patients in the Acoltramon group versus the patients that were just using the vehicle alone. The primary endpoint was to see where the patients were at 14 days after starting use. And if you're looking at the charts here, both for the Comet 2 and the Comet 3 studies, you're going to see that there was a significant improvement in their Schirmer test scores at that day 14. But not only that, if you look over at day 1 in both Comet 2 and Comet 3, you're going to see that there's a significant increase in Schirmer test scores at day 1. So this really is a fast-acting medication, and then it maintained all the Schirmer score increase there through day 90. Patients were also given a survey, which was a Sandy score, and at day 28, the patients in the Acoltramon group had significantly higher Sandy scores than the vehicle group. There was it wasn't the primary endpoint, but they also looked at ocular staining, and it was shown that there was a significant improvement in ocular staining in both conjunctival staining as well as corneal staining, and it was tolerated well with very limited adverse events. This here is a slide showing corneal staining. The top darker black line is the vehicle group, and then the lighter gray line below is the Acoltramon group. And you can see that at day 7, there's a significant improvement in corneal staining at day 7 in both the Comet 2 and Comet 3 studies, and that continued to improve as patients stayed on the medication through day 90. And very similarly here, we've got the conjunctival staining, and this was measured with lissamine green staining. And on the top line there is our vehicle, and you'll see starting at day 7, a significant improvement in conjunctival staining that continued to improve and was maintained through day 90 as well. So very effective there. Safety and tolerability. This is really a safe medication that patients tolerated well. There were really no adverse events that occurred on patients in the Acoltramon group, as similarly with the vehicle. The patients who discontinued use was very low. It was 2% or less, and it was really pretty similar in the Acoltramon group as well as the vehicle, so that wasn't a cause for a dropout in the study. The really big thing to note here is that about 50% of the patients in the Acoltramon group did mention significant burning or stinging upon instillation. But with that said, of that 50%, 98% of those patients did describe it as mild burning and stinging. 86% of those patients said that burning and stinging lasted for 1 minute or less, and less than 1% of the patients actually dropped out of the study. So kind of to summarize here, this is really a great new tool that we have in our toolbox. It is fast acting. You'll see patients improving within the first day. We're going to see patients tolerating it well. And we'll see kind of what the future holds, but I'm excited about this new technology. Questions? So currently, everybody gets it for $0. The first it's not the first 60-day supply or 60 vial supply is $0 for everybody. It does have actually pretty good coverage under a lot of insurance plans. And Alcon is who is marketing this product. They have a cash pay option for patients, which actually is quite affordable. So any patient that has a PA denied or it's too expensive, they can opt in for the cash pay, which I believe is $79 for the box of 60 lenses. That is supposed to be a 30-day supply, but I won't tell you that you can stretch it out to 90. Any other questions? Yes. None that's been reported. There were absolutely no adverse events in the study. Time will tell, but as of now, no. All right. Well, thanks, everybody. We're going to invite Dr. Lauren Mancinelli here. She'll be talking about IPL and amniotic membranes. Sorry.
All right, so my name is Lauren Mancinelli. I graduated from the Indiana University class of 2022, and since then I've been with Northern Virginia Doctors of Optometry over in a bunch of different locations throughout Virginia. Had the opportunity to do a specialty rotation in my 4th year in dry eye, and have kind of fell in love with the project ever since. All right. So to start, just wanted to talk a little bit about what our typical dry eye workup looks like. Always starts with a very thorough history because we like to get a little bit more in depth than you can typically during a comprehensive eye exam. Really want to understand a patient's ebb and flow of symptoms, if there's any kind of pattern, and it helps you narrow down treatment options before you even start to see the data, just based on how they kind of relate to their dry eye. We use the keratograph during every eval also. It gives us a lot of really good objective data, not only to help track their progress as they progress through treatments, but it also helps to present to the patient their kind of custom profile of what's really targeting their own ocular surface, whether it's evaporative, aqueous, or more inflammatory based. Patients also really love to see the HD photos of their lids as well if they've been dealing with any kind of bleph issues too. We all are very familiar with drops as the first line of treatment, but now that we have more technology, more research into dry eye, we have other options that really target more specifically certain patient concerns. So just going to touch mostly on IPL and then a little bit of brief introduction to amniotic membranes before a more in-depth presentation later. Your ideal patient for IPL is going to be that fair-skinned, super inflamed lid. IPL itself targets anything that's pigmented or melanated. So if you have a darker skinned patient, you run the risk of hypopigmentation or burning as more melanin absorbs the energy from the IPL. Main takeaways from IPL, if you haven't had any experience with it, it is fabulous at eliminating those accessory vessels that help bring inflammatory markers to the ocular surface. Through the lysis of the vessels, they've actually shown in studies a reduction in certain cytokines and prostaglandins on the tear surface. And then we use something called radiofrequency as well with the light energy from the IPL. So the radiofrequency increases collagen production and can help reinforce the gland structure. So for those atrophic glands, or if there's any kind of dormant tissue, sometimes it can actually reawaken a little bit of that activity as well to increase meibum production. The radiofrequency and a low-level light therapy, which basically just starts biomodulation at the surface with lower energy levels, and controls inflammation on a more surface level, can also be used separately from IPL. So if you do have patients with lots of inflammation who may have darker skin or other contraindications to IPL, you can still treat them at a very basic level to help accomplish the same kind of task. We have some nice before and after photos. I don't know if we can pull up, this is actually an earlier copy. I don't know where Anne is. Well, I had some nice photos. I can email them out so that everybody can see them of a great before and after. But here you can see on the left, this woman underwent 4 treatments of IPL. We like to space them about 2 to 3 weeks apart. Gives the opportunity to get some exponential growth when you do them that close together, but it's not so soon that you run the risk of burning or peeling on the skin. But you get a great view of how well it targets those dark lesions, especially on her face. And again, this is only after 4 treatments. And so the increase in collagen production also helps eliminate some of the signs of fine lines and wrinkles, which people really love. At our practice, we do treat the whole face as a courtesy because you're there anyway, so might as well get some good cosmetic benefit out of it. Lastly, here, just want to touch briefly on amniotic membranes. The amnion is that inner layer of a placenta. A lot of them are just donor placental tissue that go through a sterilization and preservation process. Two forms, dry and the cryopreserved, which is the hydrated. Our clinic typically uses the hydrated a little bit more. We love a self-contained amniograft. Here is the Procera on the left, and then their newer model, the CAM 360, which is the ringless amniograph on the right. Previously, the amniotic membranes have kind of been reserved for more moderate to severe cases, but now with newer technologies, designs, and better ways to make them more comfortable for the patient, we've been integrating them a lot for earlier signs of surface disease. So patients with persistent SPK who maybe aren't a prime candidate for steroid therapy before you start them on drops, you can use an amniotic membrane to really clean up that ocular surface. This is a photo of a patient of mine who has glaucoma, is on a ton of drops, so we didn't want to put her on long-term steroid therapy. You can see she's got some pretty rough SPK up there, and then after 3 days with the traditional Procera, which is the one with the ring, she has a beautiful ocular surface and has been doing really well on Cequa ever since. It's a great way to just make sure a patient is very comfortable and also adds a little bit of protection to the surface while you let the membrane do its job. These cryopreserved membranes retain a substance called a heavy chain hyaluronic acid, which is incredible for protecting against scarring. It helps clear up haze, and it has shown to have some impact on some corneal nerve regeneration as well. So great for not only the neurotrophic patients that we typically use membranes for, but also for patients to avoid kind of trending towards that zone if they're in a mild to moderate dry eye state. In conclusion, we know dry eye is very prevalent now that everybody's on digital devices most of the day, and certainly post-refractive surgery patients can all benefit from a little extra dry eye care. But there's ways now that we can go beyond drops. So a patient really feels like they're being listened to, their actual problems are being addressed versus just being told to get some artificial tears or some Restasis. And it's a great way to build patient relationships and maintain that long-term trust with your patients. In addition, it's great for revenue as well. So everybody kind of wins. But with the new advancements in technology, hopefully y'all can reach for some additional things beyond dry eye or just dry eye drops and integrate some IPL. Anybody have any follow-up questions? Yes. So it is costly. It's all cash pay. Insurance does not cover anything as soon as they hear the word cosmetic. They're not interested. With the keratograph, we do meibography. And so we're able to show a patient if they do have atrophy or gland dropout, kind of the significance of that. The visual helps explain why we want to do something a little bit more targeted or a little bit more intense. A lot of the patients appreciate being told exactly what's going on. So once you say that the IPL specifically helps control the inflammation that's leading to that gland atrophy, they're pretty eager to try it because a lot of the patients are the ones who have tried everything. They've been down the road. They've been dealing with it for years and haven't seen improvement with anything else. For just the vanity standpoint too, once you tell them it's going to get rid of some of that fine lines around the eyes and the mouth, they're pretty game for it as well. But the data and the research does show that it has a significant improvement in symptoms, and patients are usually really receptive.
Great. Thank you.
Any other questions? Yes. Oh, no longer than about 10 minutes. The longest piece is if a patient wants a little bit of numbing because it's not the most comfortable spa treatment you'll have. It does feel like a little heat, like a little snap if anyone here has done laser hair removal, really similar. They just sit there for 30 minutes with the lidocaine gel on their face, totally optional. The actual treatment time is very quick, so it's about 10 minutes of discomfort. Yes? So the radio frequency doesn't actually use any light energy. It's just pulses of little vibrations. So that's why you can use it safely for those darker skin tone people because there's not actually any light energy. It's not attracted to melanin similar to the light. It's just vibration. Yes. Anything else? All right. Thank you guys for listening. We'll turn it over to Dr. Siddiqui.
All right, so I guess I'm going to be the first speaker on the stage. So thank you all for being here on a Sunday morning. So I'm glad we're all somewhat awake. My name is Aazim Siddiqui. I'm a cornea and refractive surgeon at Solomon Eye Practice. Can I get the, thank you. So who thought that lip fillers could be used in the eyeball? I don't have any financial disclosures. So we all know the dry eye challenge is massive. So it affects millions worldwide. We have a bunch of treatment options that are out there, various concentrations of cyclosporin, lifitegrast. We just heard about IPL, and then punctal occlusion's been something that's been used for decades, and it's worked pretty well. But usually we've used plugs, we've used cautery. But there are certain limitations to those devices. You can have a risk of extrusion, infection, canaliculitis, and there's a certain element of irreversibility to it. So that's where Lacrofill comes in. It's a cross-linked hyaluronic acid gel filler that gets placed into the canaliculus, and it allows for the occlusion of the puncta. It provides temporary occlusion anywhere between 3 to 6 months. It's designed to improve tear retention without permanent alteration. So it's an office-based procedure that you could do in your exam lane. It's minimally invasive. The gel is placed inside the canaliculus via a micro cannula. Don't worry, it's not a needle. And it's a single vial, single syringe. It provides full fill of the canalicular system. So it creates a viscoelastic plug, and it causes slower tear drainage, so more availability of tears on the surface of the eye. It's biodegradable, and it's gradually resorbed over time. And it's easily removed with irrigation. And then can we mute the audio? Thank you. So let's watch the video. Can we go back to the video? Here we go. Okay. Can we play the video? So this is a video of Lacrofill being placed in the puncta, and you can see it's a pretty somewhat straightforward, but you just have to be somewhat dexterous in order to maneuver the cannula into the punctum and deploy the viscoelastic gel. Sorry, I can't see the video here, so I'm not sure where we're at. Okay, so we're basically just injecting at this point into the puncta. And you could do it at the slit lamp, but if you still have some of your accommodation left, then you could try to do it without the slit lamp. And no shade. Wonderful. So advantages over traditional plugs. So there's no extrusion risk, no risk of any lesions occurring. Like sometimes you can get a papilloma happen like right next to the puncta. It's biocompatible material, hyaluronic acid. It's temporary. It's reversible, unlike cautery. And patients are surprisingly more open to the idea I've found of Lacrofill as opposed to plugs. They just don't like a foreign body just sitting there on their eyelids, in my opinion. It's better comfort. There's no foreign body sensations. Sometimes patients can feel plugs. And it's customized for each individual, so you decide if you want to just do the lower puncta or all 4 of your eyelids. It's totally up to you. You can titrate it based on how dry the patient's eyes are. You can repeat it as much as you want. And clinical outcomes have shown significant improvement in Schirmer scores, improvement in tear breakup time, and symptomatic relief on the OSDI questionnaires. And they've overall showed good tolerability and minimal adverse events. And it can be combined with other dry eye treatments. So it's not here to replace things. It's here to kind of just add an option to our dry eye paradigm. Indications, moderate to severe dry eye, contact lens intolerance, post-LASIK ocular or ocular surface surgery eyes. Limitations, it is temporary, so there's a certain you have to repeat these maybe every 3 to 6 months. You have to consider costs, based on plugs. In your practice, you have to make cost-related decisions. And then limited long-term outcome data. It's still emerging. Future. So we're gonna customize. So we can have customized dry eye algorithms going forward, and Lacrofill could be sort of its own thing, its own bucket, and it can be used in combination with other biologics, other anti-inflammatory, other dry eye treatments that are on the market, and maybe it'll replace punctal plugs as a first-line treatment. So in summary, it offers a novel, minimally invasive way to retain tears. It's safer and more comfortable than plugs, unlike cautery, and clinical outcomes have showed improved signs and symptoms of dry eye, and it represents an innovative step forward in punctal occlusion therapy. Thank you so much. I didn't put my email on there, but just come and find me. So thanks so much. Sorry, questions? Yes, go ahead. So approximately every box is typically, I think, like $70 to $100, but you could technically titrate it and use it for multiple eyelids, multiple patients, because it's literally a vial, so you decide how much you want to dispense out of it.
Is it covered by insurance?
Yeah, so it's the same code as temporary plugs, essentially, so you could use that same code.
You said there was other pending uses. What would those be?
So, I mean, the future could be that potentially this comes in the form of like a medicated gel, so you could introduce some dry eye actual like treatment within Lacrofill, or have other treatment things like glaucoma medications could be part of this, or steroids after cataract surgery, for instance. So that could be a potential future direction.
Do patients feel it at all, like a sensation of fullness?
Yeah, that's a great question. So it's interesting. As I'm doing it, patients often feel like, yeah, I kind of feel like a cool sensation going into my eye, but after a minute or so, they just no longer feel it after that. So I've never had that complaint.
Yeah, just to save some time, Dr. Adamopoulos, if you want to come up on stage, we're going to be the backdrop here for Dr. Schwartz. This is Dr. Beth Schwartz, who will be talking to us about neurotrophic keratitis.
Hi, I'm Beth Schwartz. I'm one of the associates here at Solomon Eye Physicians and Surgeons, and I am talking about neurotrophic keratitis. Okay, so I have no financial interests or use product here. Neurotrophic keratitis is a rare degenerative disorder caused by trigeminal nerve dysfunction. This leads to impaired corneal sensitivity and epithelial breakdown and potential ulceration and perforation. So what are the causes for neurotrophic keratitis? We all know that when you see patients who have herpetic diseases, for example, if they come in and they have herpes zoster or herpes simplex, that would be the one thing that we think, oh yes, neurotrophic. But there are other causes that can actually lead to neurotrophic keratitis. One being, importantly, drug toxicities with certain medications, particularly ones that contain BAK and other preservatives. Another thing to think about is anesthetics. This is a big one for all you guys, is contact lens users. I always have those patients that come in, I'm guilty of that as well, who have decreased corneal sensation from contact lens overwear and their long-term contact lens use. Certain neurologic diseases, such as having a CVA or having MS, and even having had diabetes, there could be a neuropathic association, surgical traumas, tumors, and so forth. Okay. The pathophysiology is pretty straightforward, and it's written in the top slide, which is the magenta slide. Basically, you have trigeminal nerve damage and dysfunction, which can lead to sensory denervation, and that can actually lead to a lot of ocular surface disease, and tear film osmolarity goes way up, leading to poor wound healing, ulceration, and possible perforation. Okay, so how do we define neurotrophic keratitis? We usually define neurotrophic keratitis using the Mackey classification. There are 3 stages to this classification. The first stage, we usually see punctate epithelial staining. In the second stage, you'll see persistent corneal epithelial defect with rolled edges. And the third one, you can actually see actual stromal melting and perforation. Okay, so clinical clues. All right, so you have a patient coming in and, you're doing all these modalities, you're doing lubrication, using medications, but they're just not healing. So when you have a non-healing corneal epithelial defect, you should have a little buzzer going off in your head saying, hey, maybe this is a neurotrophic process, which should lead you to maybe take like a little wisp of cotton and try to see if you can do a little test to see if the patient feels the little cotton on their eye. Usually, as you know, you get the blink response. But for neurotrophic patients, they just kind of stare there and stand there and don't really react. So lack of discomfort, minimal inflammation, those are key indicators that there might be a neurotrophic component, and you want to kind of investigate that further. Treatment strategies, promoting healing, preventing progression, and addressing the underlying cause. So let's look at those stages again. So stage 1, we said there's punctate staining. Mostly you have preservative-free artificial tears, and you want to discontinue toxic drops. People have been using steroid drops as well as cyclosporins as well in the stage 1 process. And for stage 2, that's pretty much by indicative of seeing a corneal epithelial defect. Interesting slide. So the first mainstay of treatments usually start to use antibiotics, whether they're topical or oral. Other options include bandage contact lenses, as you alluded to before, membrane grafting, and very early on they've actually been instituting corneal cross-linking. One of the newer medications happens to be Oxervate, which is synergamine, which is actually recombinant human growth factor, and it attaches to anterior segment receptors, stimulating nerve reinnervation and that would then lead to tear production, that would then lead to a more moistened eye. It's usually given every 2 hours, 6 times a day, and usually it's used for 8 weeks. The third stage is basically corneal melting, and that would basically be more of a surgical intervention. So here's a little slide that actually shows in the beginning. So baseline, you would see the corneal epithelial defect is larger, and then after about 8 weeks of treatment, you see how there's no longer that fluorescent staining on the cornea, and that the actual lesion heals. So basically, take-home messages. You want to keep neurotrophic keratitis in mind and keep it on the radar when you see a non-healing corneal epithelial defect. Simple testing, such as just using a wisp of cotton to check corneal sensitivity, can make the difference between visual loss and recovery, and actually making that catch pretty quickly. And also, you want to apply several treatment strategies, including synergamine. It's pretty. So the medication has very little side effects, so it's actually a pretty good drug. And then, thanks. That's my email address, by the way. Any questions?
I do. So when you're starting a patient on Oxervate, are you then removing any of the other medications that they're on in order to avoid toxicity to the cornea, or are you maintaining things like cyclosporins during the duration of your Oxervate treatment?
So that's a really good question. I see. You can, and you want, because so cyclosporin is actually preservative. Is actually preservative free, so you really pretty much can. However, you don't absolutely need to use other medications because the Oxervate is really helping regenerate, and it usually does work pretty quickly if it's going to work, so that you don't really need other medications simultaneously used with it. I do want to say that I actually have had a patient where I've actually had to use Oxervate a second time around because in order to get better results in corneal regeneration, nerve regeneration.
Great. Thanks so much for that.
Thanks.
Thanks, Dr. Schwartz. Next, we're going to have Dr. Andy Morgenstern coming up, and he'll be talking to us about our favorite mite, Demodex.
Thank you. Good to see you. Thanks, guys. All right, so we're going to pick up the pace a little bit. Good morning. Good morning. Thank you very much. Okay, good. So we're alive. Everybody coffeeed up. Coffee's in the back, caffeine. I just want to say thanks to Ann and the team in the back over there. I know what running a meeting is like. I kind of describe it as like 3 weddings and a bar mitzvah all squeezed together at the same time. These are not easy. So thank the team for putting this together. We got great high quality education here. And like Dr. John Solomon was saying before, please thank the sponsors at every single meeting that you go to, because without sponsors, these things don't happen. So thank you very much. So I'm going to try to pick up the pace a little bit, catch up in the air. We're going to talk about Demodex blepharitis real quick. I think, does anybody here never heard of Demodex blepharitis before? Okay, well, we'll chat with it. Never? Yeah, we'll talk about ophthalmology later. Okay, my disclosure, I work at Walter Reed. I am not being compensated for this lecture. I am a member of the Tarsus Speakers Bureau. I have no financial incentive to present this information, and I am here representing myself with publicly available information. I am not representing the U.S. government in any capacity whatsoever today. We do have to say that. So what is Demodex? For those of you, I think we all know this, but quick review. Demodex mites are a microscopic organism that live on the human skin. There's 2 main types, follicularum and brevis, and they inhabit the hair follicles around the eye, well, really anywhere on the body, but they can infest dramatically to impact our lives around the eye specifically, and most adults carry them. The high likelihood is that everybody sitting in this room has some level of Demodex going on themselves right now. It lives in the hair follicles. They're about 0.2 to 0.4 millimeters in size, and they're invisible to the naked eye, and they're clinically relevant to us. And so I know these are all kind of basic Demodex slides, and I know that we all see it, and I know that we all know what it is, but just a quick review. And then I want to give you a quick analogy on something that you haven't thought of yet and why we have to look for it. So it can cause eyelid inflammation, itching, burning, foreign body sensation. It can lead to rosacea and dry eye disease, and it's obviously a very important consideration in the management of ocular surface disease. And for really what this symposium is really all about refractive surgery. You have to remember, and after living in the refractive surgery world for many, many years, ocular surface is equal to refractive happiness, especially after refractive surgical procedures. And for the surgeons in the room, management of that ocular surface disease prior to the surgery will make their life a whole lot easier, and everybody's life easier afterwards. So just really, this is really, really important. There are 2 main forms of Demodex. There's the male form, and this is what it looks like. Very important to manage. And then there's also the female form that you have to look for as well. Sorry, that was too easy, and I've gotten a little addicted to ChatGPT. Most important, for those of you who open up boxes of medicine, take out the piece of paper and throw it in the trash. That thing is called the package insert, and there's a lot of great information on there that you need to know about. Here's all the prescribing information. But for those of you who prescribe medications to patients, open up your package inserts and take a look. It's going to have a ton of great information for you. I know it's silly to have to remind everybody of this, but knowing what these drugs are indicated for and why you're prescribing it is very important, especially if you're writing something off-label. So one of the things that is off-label that I will tell you about, I have had patients that have had Demodex blepharitis, and this medicine is great. I've used it on myself before because I've been diagnosed with Demodex myself that has impacted my ocular surface. So I like to talk about medications and products and devices that I've actually used on myself. I got a tremendous amount of relief. Just a real quick show of hands. Has anybody that's an eye doctor in the room used Xdemvy for Demodex blepharitis? So there's only a couple. Like I said before, almost all of us have Demodex. All of us are, nobody's getting younger in the room. We are not like wine. We don't get better as we get older. And so one of the things you might want to consider is getting yourself an eye exam. The magic happens with looking for blepharitis when you have the patient look down to look for the collarettes. I have a couple of slides of it over here. Couple of big facts that you want to know about with Demodex blepharitis. 58% of eye care patients in the U.S. have Demodex. 58%, that's a lot of patients that are coming through. And also 57%, approximately 57% of patients with meibomian gland disease have some level of Demodex that we can manage as well to make our patients more comfortable and happier. And for those contact lens patients that have a little bit of contact lens dysfunction or irritability, those patients could be made happier. The cataract refractive patients could be made happier. And so there's a lot of stuff that we can do to improve our patients' lives. So a lot of stuff over here. I think we have seen it all. We can treat these collarettes that live right at the base of the lashes, right where the lash hits the lid. But I do want to bring up a concept for you that we've talked about amongst our kind of anterior segment optometrist people. Everybody here knows what blepharitis is. Prior to XDEMVY being on the market, because that's the one FDA-approved drug that is indicated to treat Demodex blepharitis, we did not have an FDA-approved indication for the treatment of Demodex blepharitis. We had all the other tea tree oils and other stuff like that, but we actually have a product now that can treat this stuff. Just to bring this back, for those of us who have been in the refractive world long enough, before 2005, 2006, 2007, we did not have pentacams. Okay, and I know this is a little bit of a stretch, but it's not really. Before we had pentacams, we looked at the anterior surface of the cornea. Once we learned that we had a device that could actually look and image the posterior side of the cornea, we did not go back. We started using it for its capability, and we implemented it in care of patients. Before we had an indication for Demodex blepharitis, we had a bunch of over-the-counter drugs that could actually help but not really cure a lot of these things. Now we have something on the market that can treat this condition. We know how many patients have Demodex, we know what it causes, and we know what it does. In my personal opinion, you really need to consider all of these FDA-indicated medications and devices that are used specifically for that purpose. Just like we implemented pentacams, and nobody in this room that sees refractive surgery patients does not use a pentacam to look at the posterior segment of a patient's eye. For those patients that are treating Demodex blepharitis, I don't understand why you wouldn't consider using a drug like XDEMVY, and I know that's the only one on the market. If there was another one, I would talk about that one as well. But that's the indicated drug that we have to treat this condition. In my personal opinion, as technology moves forward, as pharmaceuticals move forward, I think it's really important to understand that we have a tool belt to treat dry eye and ocular surface disease. You need to use all those tools in your tool belt to get to the solution phase. So we have a great product that's out there. Again, I'm not here to promote the drug, but that's the FDA-indicated drug that's being used for this condition. I think everybody should kind of remember that while they're looking at their patients and seeing and noticing that these patients have Demodex. With that, I just want to say thanks. Hopefully I sped up the process a little bit. I was talking a little bit quick. And I guess this is the part where you guys ask if there are any questions, I think, right?
Any questions? Actually, where are we with time? We're good. All right.
We're good?
Questions?
Sorry, I can go through a couple of slides that I skipped over. Go ahead. Yeah, sure. Yeah, sorry. I'm sorry? What ICD code do I use for Demodex? To be honest with you, I forgot what I used, but I have my whole list of codes written down in my exam room. Does anybody have any suggestions on what they use to code Demodex in there? Okay. Any other questions?
We can send that out in an email to everyone as well. So.
Yep. Any other questions? Yep. Andy? Do I believe that 100% of the collarettes are from Demodex? I would say nothing in medicine is 100%, is what I would say. Is there, of the people that did the studies, the Saturn 1, Saturn 2 studies, and all the people that do these studies, from everything that I've seen, patients with collarettes, when they've actually pulled out the lash and looked to see if there are mites there are mites there. Okay, the collarette is not the mite. The collarette is actually the debris that comes off of the Demodex mite that lives at the base of the lash. So I will tell you that the XDEMVY, the Tarsus people, the XDEMVY people will definitely tell you if you see collarettes, that equals Demodex blepharitis. Is that the case 100% of the time? I am sure there could be exceptions to the rule, as there are in everything in medicine. So I guess I'm saying maybe is a good answer.
All right. Well, thank you, Dr. Morgenstern. Yeah, so right. I think we need to move forward. Sorry. We will have questions that can be available afterwards, and you can always email anybody with any questions that you have. Thank you. Next up, we have Dr. Alan Glazier, who will be talking to us about amniotic membranes.
Thank you, thank you, thank you. Thank you, everybody. Thank you, Ann and the team and John and everybody else for putting on such a great thing. What Dr. Mancinelli said, I know we're behind, so I figured, there you go. I'm here to talk about amniotic membranes, and I'm going to try and whip through this. These are my disclosures. We're going to talk a little bit about the fetal environment, which separates the mother from the fetus, obviously. And in that environment, the fetus is floating in the amniotic fluid. Sounds nice, right? I kind of want to go back there sometimes. It's in suspension, and in there, in the fluid are stem cells, and in the amnion, which is the inner layer that you see the red in red, there are also stem cells that differentiate into the different organs that we call mesodermal lineages, which form the different organs and systems in our body. It's avascular. It lacks T cells. And how do you scroll down on the notes? Or I just have too many notes. Yeah. Okay. Anyhow, so and then the amnion is attached to a tissue called the chorion, which is thank you for doing that, which is the outside. It's the outside here. It's a strong tissue which separates the blood of the mother from the baby and stops all kinds of problems from happening. And in harvesting these things, they're scraped in utero from the placental tissue. And so if any of your patients are concerned about the fetus being harmed, anything like that, it's not touched at all. It's just taken after delivery. It's seronegative, making sure that it's screened for HIV and other kinds of infectious like HIV, syphilis, and the like. And then, let's see, move on here. It's washed, and the whole purpose of using these membranes is to stop the cascade of inflammation that leads to scarring and damage to the cornea from uncontrolled inflammation. So as you can see in this graphic, you want to control the inflammation and promote healing and stop the bad cascade in red there. You can use other things like steroids and NSAIDs and doxycycline and things like that, but this is a highly effective way of doing it. In many conditions, it also helps the limbal stem cells, which move into action so that they can do their job better because they're damaged as well. The biggest part of the inflammatory cascade that causes damage is the T cell response, the cell-mediated immunity, which are the neutrophils, which are released, and they have a job in phagocytosing or eating up everything on the cornea that's causing the inflammation and the damage. But if they're left on there too long, they die and they phagocytose themselves. So then the macrophages, the big cells there, come around to eat up the dead and dying neutrophils. So that's kind of what happens. This is a picture of this in action right here. In the amniotic membrane, what's working and what's helping people is that they lack immunogenicity, meaning they suppress the immune response. They also are avascular, so the antibodies can't get in there and create the reactions that lead to inflammation from the immune response as well. They act as a scaffold, so they allow cells and tissue to reestablish themselves on the cornea and the epithelium and build it and help it do its job again. There are essential growth factors in there that are anti-inflammatory as well, anti-fibrotic. We're going to talk about more of these in the succeeding slides. Fibronectin is a big part of this. Fibronectin is secreted by fibroblast cells, and it has a role in cell adhesion, cell growth, and the healing process from a structural standpoint. And then elastin, which helps. Once the fibronectin lays down, the elastin helps with the elasticity of the tissue and the connective tissue in terms of its ability to bend and change and move around. And then nitrogen, which has a lot to do with, it's a bridging molecule with basement membrane. So it helps the epithelium and the collagen, specifically collagen 4, stick back on and do their jobs as well. And then hyaluronic acid, which was talked about already. Corneal collagens, and the corneal collagens, let me go back here, that are in the cornea, cornea 1, 3, 4, and 5, which are basically the structural collagens that make up the stroma. There's corneal 4 in the basement membrane, and corneal 4 is a critical factor here, probably the most important collagen when it comes to healing as related to amniotic membranes. And there might be collagen 7, arguably, in there as well. There's other proteins. We don't have to go into too much of these. And I'm happy to share this deck with anybody that wants it so you can read through it. and protease inhibitors, which we're all familiar with, the medicines they use to treat HIV and other types of viral infections. Those are in this tissue as well, and a ton of other factors, interleukins, which are anti-inflammatory molecules as well. The types of membranes are dehydrated and cryopreserved. Now, dehydrated can be stored for 2 to 5 years. They sometimes you can use them with a bandage contact lens, which helps put them in more effectively. The cryopreserved have to be stored in a freezer, and they have a 1 to 2 year shelf life. Costs are like about $1,000 for the cryopreserved. But the big difference between the two of them is in cryopreserved membranes, they retain a lot of these molecules we just spoke about. And the dehydrated membranes, to get them dehydrated, they have to heat them up. And once the temperature is past 98 degrees and goes up from there to heat them up, it kills a lot of the molecules that aren't killed in the cryopreservation process. So the dry membranes aren't as effective in certain situations. They're more to help rebuild the scaffolding, whereas the cryopreserved have a lot of these molecules we talked about that aren't in the dry membranes. And these are some of the conditions that they're indicated. And of course, the number one and most important condition is limbal stem cell deficiency. But everything the other speakers spoke about, a lot of the corneal conditions that relate to dry eye are helped by membranes, as well as the therapies that we've talked about as well. Orientation with the cryopreserved, you insert them under the upper lid. I have a little video of this, but because of time, I'm going to skip that video. Again, happy to share this with anybody who wants. And then the dehydrated, I like to put them in a bandage contact lens and insert them. I don't usually use the lid speculum, but they'll dry the cornea, put the bandage and the membrane on underneath that. Let's see what we got here. This is the video, but again, I'm going to blow by that. The approved bandage contact lenses we commonly come in contact with our practice are Air Optics, Ultra, Oasis, and not Unilens. I don't have that in my practice, but not that I wouldn't, just don't need it. And thank you.
So on stage here with me, I have Dr. Dora Adamopoulos. She is CEO and founder of Eye to Eye, as well as Soma Su Med Spa. Dr. Adamopoulos is kind of here as a guest or a witness, an expert witness. She really has no dog in the fight. She didn't present any lectures, but she deals with this all day, every day. So my question for you to start out is, what happens tomorrow morning? It's 8 o'clock in the morning. Your very first patient is a 52-year-old female. She reads documents all day long. She uses artificial tears 6 times a day and complains of just red, tired eyes. Where do you start? What do you do? How do you incorporate all that you've learned into that 8 a.m. patient?
That's a great question. Good morning, everybody. So for context, 3 years ago, I opened up a full-scale medical aesthetic center. I have a medical director who runs the operations, but as an owner and as an optometrist in the healthcare field, I took a deep dive to learn about all the things that we offer in our clinic, as well as all the techniques that are used in aesthetics, right? Techniques meaning like consultations and how they convert, because it easily applies to eye care. So keeping that in mind, when a patient comes in, the 4 things I always keep in mind are, because this is what we all think about as a patient ourselves. Does it work? Does it hurt? How much is it going to cost? What are my other options? Right? I always have that in the back of my mind. I've been a patient. We've all been patients. We go to the dentist. We go to derm. Those are the things we worry about. Then in terms of the consultation, every encounter is a consultation, no matter if we like it or not. So the patient comes in, she's 55 years old. She's been using drops. She doesn't tell your tech any of this, of course, right? So we sit down. No complaints, and then as soon as you sit down with them, they unleash everything. They complain about, my eyes are red, I don't like how I look, I feel tired, I've been using all these drops, I've tried everything, nothing works. So the things to remember that I feel are super important in a consultation are, what is the chief complaint and the emotional response to that. Repeat it back to them. So I would say to her, so she knows that I'm listening, so it sounds like you feel really frustrated using all of these drops. You hate the fact that your eyes are always red, and you've tried everything and you just don't know what to do. And they'll nod, yes, because you heard them. And it's called a mirroring technique, because they use that a lot with the FBI to repeat back when they're interrogating people, but they use it a lot in sales. Then the next portion is, The examination. So I will tell her, Mrs. Jones, I'm going to examine your eyes. We'll go over all the findings afterwards. We always do an anterior seg photo and a meibomian scan of the lids. So I pull those up at the end and I say, I see some things that concern me. And I pause. Okay, if your doctor tells you that, are you going to listen? Yes. So I have her attention immediately. I'll show her her glands. I show her her lids. I show her Demodex. I show her why her eyes feel dry. I'll show her why her drops are not working. And then I'll, so we educated about what's happening. And then the next thing you do is you talk about your competitors. So in the healthcare field, it's not really bad-mouthing another doctor, but you'll say, most of the times you'll hear, use a warm compress. Use Johnson & Johnson baby shampoo on your lids. So I'm referencing things that the patient has already researched. All of you research things before you go to a doctor. So this is an opportunity for you to acknowledge what's on the internet and tell her that, those are the things that are not working anymore. And then the last component is results. We have a mini iPad in the office. We take all of the IPL before and afters, all the meibomian glands that we've cleaned up, all the lids we've cleaned up, and we just do a quick boom, boom, boom. These are some patients that we've helped. So in a matter of a few minutes, I have addressed her concerns. I've examined her. I've shown her what concerns me. I've talked about other modalities that other doctors may have recommended, and then I give her my results, my plan.
I guess my question then is, and similarly to the question to Dr. Mancinelli, how do you now then convert these patients? Because you've given them all of this compelling evidence as to why there's something that needs to be fixed. How do you then turn that into a patient that's going to come back and pay for these, more expensive, non-insurance covered procedures?
Sure, that's a great question, because remember, cost is one of the first 4 things we always think about. So we have a dedicated person at the office who goes over, who's our coordinator for myopia, for my dry eye, because somebody else has to do the money talk. If you go to the dentist, if you go to a plastic surgeon, if you go to a dermatology practice, they have a dedicated person talking to you about that. We should too, because we're not there to explain cost and why insurance doesn't cover and so forth. I will sometimes just say it's $500 a treatment. We offer packages and we offer financing. Financing, we need to also think in a broader scope. So we usually use Care First, but in the aesthetics world, there's so many different financing plans. One that we've incorporated is called Cherry Financing. It offers you the ability to have a lower credit score. It still gives you 0% interest. It gives them payment plans, and we still get our money. So giving them the option of being able to pay for things, especially with things changing in the economy, is very important.
That's great. And now, who is doing the procedures? Are you doing the IPLs? Do you have a technician or trained aestheticians that are doing the procedures?
Because we've had the devices for a while, we feel comfortable with our doctors doing the IPLs and the technicians doing all the radiofrequency OptiLift procedures.
That's great. And who is then performing at what point are you bringing the patients back for a follow-up? Are you seeing them monthly, biannually? What is your follow-up
So
protocol?
in terms of revenue, this is not only converting the patient for the IPL procedure for revenue, but just a regular billing them with CPT codes. So 99213, 92285 for the photo, 0507T for the meibomian scan. We do that at every visit other than their annual. So we have the annual exam codes. We have every follow-up, we do those 3 procedures. So you're seeing them 3 to 4 times a year at least on top of their annual exam. So not only do you have a patient coming back, you're building trust, they're getting to know your staff, they're getting comfortable coming to your practice, and that is a great general organic way to increase revenue without even, promoting a non-pay service.
And so who do you think is the ideal candidate for these types of procedures?
Everybody. So one of the things that I've learned also from aesthetics is that they like to have a really healthy body, eye, limb before a plastic surgeon will, do the procedure. So I have been at conferences with plastic surgeons who say, I would like to have their skin in the best condition possible. I would like to have their muscles as tight as possible before I do lipo or before I do a facelift. And a perfect example was it was a plastic surgeon, not in this area, and he does lipo, a lot of weight loss clients. And he tells them they need to do this treatment for a muscle building radiofrequency device for their abs because he wants their muscles in the tightest condition possible under the fat before he goes in to remove the fat, right? And that made me think, I was like, okay, what do we do, that we can help our surgeons? Where people are having blepharoplasties, people are having cataract surgeries, people are having refractive surgeries. Why are we sending these patients to our surgeons with corneas and lids that are a hot mess? I think we need to, it's our part to clean them up, get them as prepped as possible. That's going to be the best surgical outcome. The surgeon will remark and say, wow, your eye is in such good shape. Wow, your eye is not so dry like I normally see. The trust is being built. They send the patient back, and you continue to watch them. So it's a win-win for the patient, for the surgeons, for everybody. And one of the things we have to keep in mind is I think we owe due diligence to the eye care community to raise our levels of how we speak to patients and what we offer. Don't forget, patients are researching. Before they've gone into your office, they have researched, they've Googled about their condition, they've Googled about you. So if we all are saying the same thing, we need to fix the Demodex, we need to clean your lids, we need to fix your glands. No matter where they go, they're going to get the same kind of consultation. And then that provides a really uniform playing field for everybody, and everybody benefits from it. Instead of just, one person having it and saying this and the other one doing that, I feel like we should all be in the same playing field. And people do pay for services. So I'll have a patient in one office who fights about a $50 copay, and then they walk 2 doors down, and they're just laying their credit card down for thousands for something else. So it's the thing.
Well, thank you, Dora.
Dr. Holzman has a question. Stop.
What would you consider a good conversion rate on your patients that are paying cash?
The goal is above 65%.
Wow.
That's what we've set for ourselves. Ideally, it could be really high, but that would be a good conversion.
Well, thank you, Dora, for
You're
that
welcome.
expert testimony on comprehensive dry eye care. We really appreciate your knowledge and expertise on this topic here. All right, one more.
Dora, I know you're great at many things. One of the things that you are great at is like branding. So that's great for patients that are in your office. How do you get them in? Do you co-brand your two businesses? And then talk about trademarking.
Oh my gosh, Jen, that's like
Jen,
after
you're
hours
killing us here on
conversation.
time.
So no, I mean, we all brand ourselves. So you have to just continue the messaging. It's not one platform versus another. You have to do all the things, unfortunately. Blogs, social, newsletters, have a good website. Referrals are our number one source. Patient referrals. My friend told me, my neighbor told me, this doctor referred me. Like it or not, we're in the business of sales and marketing. And as healthcare providers, we hate to hear that, but you are selling yourself as a provider. People are looking to capture some marketing words or, what do you offer versus somebody else? And at the end of the day, that's what we have to do to grow our business.
All right, thank you. We're going to cut questions at this point in time. Hopefully at the end we'll have some extra time for questions. You can always email anybody. But we're going to move forward to our second session. Thank you all for joining this first session. And our next session is going to be Refractive Surgery 2025.
Thank you.